Good evening. Thank you, Debolina. Good evening, everybody. Welcome to the ICA webinars on Wednesday evening. And you'll be glad to know that we celebrated the 100th webinar last Wednesday, which I'm sure you all attended and enjoyed. So continuing with the series of the ICA webinars, we have another very important one today that's on chronic pain management, which is unraveling the complexities of chronic pain management, which is a very, very complex topic. We have had several topics on pain, acute pain and chronic pain, but these are the areas which probably have not been touched upon. And as the ICA academic program, we are going to now discuss this. For this, of course, we have three eminent speakers, but more than that, in addition, we have two senior stalwarts in pain management, and they are Dr. Baljit Singh and Dr. Ashok Saxena. Neither of them really need any introduction, but again, for the formality, we have to, I'm so proud and so honored to have Professor Baljit Singh with us. He's, of course, a founder, member, and trustee, and the CEO of the Indian College of Anesthesiologists, and naturally is doing a very active member. In addition, he was the ex-director professor of the Department of Anesthesiology and Intensive Care at the GB Pant Hospital. And after that, now he is at the SGT Medical College Hospital and Research Institute, Budera, Gurgaon. Thank you, Dr. Baljit. Of course, I know it's your college, and so you are, of course, the host, but today it's my duty to welcome you. Welcome, Dr. Baljit. And our second moderator, none other than Professor Saxena, Ashok Kumar Saxena, who is a stalwart in pain management. Everybody in India and many people internationally know him. So that goes without saying. He is the professor and head of the Department of Anesthesiology, Critical Care, the University College of Medical Sciences, University of Delhi, and the GTP Hospital, Delhi, India. He has a lovely CV, and which you can all see there. He is currently the Vice President of the Indian Society of Study of Pain. He is also the recipient of several awards. One of them, of course, is the IASP, the International Association for Study of Pain, Washington, where he got the Global Award for Excellence in Pain Research. He's also the Vice Chancellor of University of Delhi. He was awarded felicitation on the occasion of Doctor's Day. He has received State Award from the Chief Minister, also awards for the Lifetime Achievement by the VD Good Award, member of the Scientific Committee of the 15th World Congress of Pain, which means a lot. And he is recipient of several awards. He's also an FAMS, and he has also been given certificate of appreciation by the IASP. So we're really honored, Dr. Ashok, for you to be moderating and being with us today. Of course, you are also a very active member of the college. So maybe please start the session.
Yeah, thank you so much, Dr. Sood, for the introductory to this webinar. And you have said very rightly that we have celebrated 100th webinar, continuous webinar of ICA. ICA has been doing it, COVID or no COVID, we have been doing it regularly every week without a break for the last 1 year. And in another 2-3 weeks time, we'll be having 2 years, kind of centenary celebration, second year continuous run of the ICA webinar that we have been conducting every Wednesday, with support from all the colleagues, friends, and a lot of youngsters have benefited from these programs. These have become extremely popular and one of the most well-attended webinars that we'll be having. The other program that we'll be having in the coming month is the Institute of Anesthesiology, Pain and Perioperative Medicine at Sir Gangaram Hospital is organizing the ultrasound guided regional anesthesia training program also. That's on 10th of July. So the program will be circulated shortly, and those who would like to connect, online, they certainly can do that. And that program will be organized by Dr. Yashri Sood. Well, friends, coming to the present, today's program, This program, as already Dr. Jashu has said, is on chronic pain. And this is pain is something which everybody suffers from from some reason or the other. There's hardly any person who would say that he hasn't suffered pain. What kind of pain is a different issue. Acute pain, although we find it very, very distressing that this is very unpleasant, but then we all know that it is for a short period. We know the reason. There is an injury, there is a surgery, there is whatever. So, and the people who suffer from acute pain, they know very well that it is going to be short lasting, maybe 2 days, 3 days, 4 days, and thereafter the world will be back to normal. Whereas chronic pain is so debilitating, so devastating for the patient. The patient can't see a reason, can't see a wound, can't see an injury, but he is having very severe pain. And this is unremitting. It is continuous, day in and day out, without fail, without any respite for the patient. It is going on and on. So this is much more, I would say, troublesome, distressful for the patient, and not only for the patient. I think the patient's family also suffers along it, because they cannot see their loved one, suffering from pain day in and day out, and crying with pain and suffering from it. And to unravel the mysteries of this, we have, of course, the stalwarts here, Dr. Saxena. His CV is something to be proud of, and anybody who sees his CV, well, I'm sure he is going to salute. He's a long time friend. I won't call him an old friend. He's young. The papers may something different, but papers, I mean, like the papers in the government, the certificates may say different age, but he looks very young, and he will always remain young. God bless him. And he will be delivering the first talk, and that talk is on the topic puzzle and enigma of CRPS in 2022. Professor Saxena, tremendous pride to have you on the program. The screen is yours. Please go ahead with your presentation. Dr. Saxena, please.
Thank you so much. Right, I'll just share the screen. Thank you. Thanks for the warm introduction. I must express my deep gratitude to of course, my dear friend, Dr. Baljit Singh, and of course to Dr. Jashu for a warm introduction, ma'am. And of course, thank you so much. Thank you. Share the screen, and we have right.
Hello, Ms. Devlina, is there some network issues?
Sir, it may be from Dr. Saxena's end. Dr. Saxena,
That nearly 1/3 of the population has persistent or recurrent chronic pain.
Sir, your screen is not visible. You can stop the sharing and do it again. Yes, sir. Now we can see.
Dr. Saxena, you're muted, I believe. Dr. Saxena, you're muted, I believe.
Sir, I have sent you unmute.
Right.
Yes, sir. Please proceed now.
All right. Is it okay?
Yes,
right. Thank you. So if we really want to know that how many Indians are suffering from chronic pain, well, almost you can say 22% of the Indian population, a survey was conducted where we found that, yes, it is such a large number, which comes to almost 286 million people, 286 million Indians suffering from chronic pain. But that's a very large number. Now, how many Indians are suffering from CRPS? That is something which we need to know. Not able to change. I'm just trying to move my slide. It is not moving. Just trying to see, that why the slide is not moving. Hello.
Sir, you can do one thing. You can totally close. Stop the whole screen view,
Okay.
PowerPoint view.
Oh, stop the share. Okay. Okay.
Yes, sir. Stop the sharing and remove the slideshow mode, sir.
And then do it again. Okay.
Yes, sir.
Okay.
Like share the PPT, not the whole screen one. Like it is showing a slide.
Is it okay?
Sir, you have shared again the one PPT. Like you
Am
cannot
I
change.
audible?
Sir, you are audible. Can you hear us?
Oh, I can. Yes, I can hear you.
But I believe
So,
you still
okay.
cannot change the PPT. You can do one thing, so you can close the PPT and open again.
I'm opening it again. All right.
Okay.
So it should work out. It should work out. No.
No, sir. No. You have to close
Is
this.
it okay?
You have to close this
It is
slideshow
not-
mode, sir.
I'm stopping the sharing.
Yeah, and go to the PPT, sir, and please
Okay.
stop the slideshow mode.
Stop the slideshow mode.
Yes, sir. Yes. Because when you are sharing that only one screen.
Okay. It should work out. I'm not able to.
Yeah, now please go to the slideshow, sir. Resume slideshow, please click on that.
Okay. I think it is F5 or.
No, sir, there is option coming like resume slideshow. We can see. Please click on that.
F7. I don't know why it is not coming. Resume slideshow. Oh, yeah. That's right.
Yes.
Just a second. Why this? Yeah. It is again coming on the last screen. Yeah. Okay.
Now it is.
So that's what I was saying. Yeah. All right. Thank you. So it has such a high incidence where, the incidence being almost 5.46 per 100,000 population. The US, Indian figures are not very well known to us, but in Netherlands, it is very high, almost 26.2 cases per 100,000 population. And you can see that the female gender is much more dominantly affected with the ratio of 4:1 against the males. Well, chronic pain, even WHO has declared is a disease state. And, we can go back to the history, and down the history channel, you'll find that way back in 16th century, when Ambroise Paré had actually reported cases of CRPS, following phlebotomy, and then Michel described these cases of CRPS, but the name was not given as CRPS. It was named as reflex sympathetic dystrophy, where this particular person, way back in 1864, actually ultimately said that ultimately the general health is seriously affected. Subsequently, Sudek, Paul H.M. Sudek, he somewhere in 1895, he named it and gave it a name of Sudek's dystrophy. These are some of the cases of CRPS, and these are the different synonyms of CRPS. You can see that, you have the causalgia for CRPS2, and then you have traumatic vasospasm, you have sympathoefferent, you have mimocausalgia, and things like that. Now, what exactly is CRPS? You'll find that, different reports, 7% patient diagnosed by actual ISP criteria. So there are different criteria. That means Budapest criteria and many other criteria are there. And you'll find it's a painful disorder where you find that neuropathic pain is actually disproportionate to the traumatic injury. That's very important. And it extends, persists beyond the normal healing period. That's also very important. It is characterized by allodynia, hyperalgesia, pseudomotor and vasomotor abnormalities, and many trophic changes. But the pathogenesis is still incompletely understood. So this is where you find there are risk factors, and you find a Danish study which was done, analysis of 647 cases, where they said that even certain syndromes like carpal tunnel syndrome, you find that it is actually an early stage of CRPS. That's very important. So this whole thing is actually the tip of the iceberg. What exactly is the Budapest criteria? Now you see different criteria have been designed where the clinical one is different, the research one is different, the sensitivity and specificities are different. Now it is time to reconsider point one. The point one is typically CRPS develops as a pain disorder with patient requesting treatment within 4 to 8 weeks after trauma, right? So this is very important. Now you see that in point 4, there is no other diagnosis. That also comes. When you have described everything, then you say that there is no other diagnosis that better fits into this particular syndrome. So all those kinds of things are there. Now, what are the criteria? We said allodynia, hyperalgesia, edema develops subsequently, and you find there is functional impairment subsequently. You find, as I said, pain is disproportionate to the traumatic event, right? The patient must report at least one symptom in 3 of the 4 categories and one sign in 2 or more of the categories. Please focus your attention onto this slide where you find the sensory, vasomotor, pseudomotor, and trophic changes. Patient must have at least one symptom in 3 out of these 4. So you can see the sensory, vasomotor, pseudomotor, and the trophic changes. All right, 3 out of these 4. In this case, we see one sign at the time of evaluation in 2 or more, but minimum 2 out of these 4. Again, we say hyperalgesia. We have temperature changes. You see, from one extremity you compare to the contralateral, you find the difference of more than 0.8 or more than 1 degree centigrade. Then you find trophic changes are there. You find there are motor dysfunction, weakness, tremor, dystonia, trophic changes are there. All right. So these are important. So this is where you see when we are actually describing, there may also be decreased range of motion. Now, compared to the previous ISP criteria, the Budapest criteria, which is very famous and normally utilized in day-to-day practice, it has a similar sensitivity, but a higher specificity. That is very important. The sensitivity is 0.99. The higher specificity is to the range of 0.68. Now, this picture describes the event, the sequences which are happening all around. We'll talk one by one about all these, the mechanism of CRPS or RSD. But there is a vacuum in the evidence in CRPS. Not many randomized controlled trials are there when we'll talk about therapeutics. So that has to be kept in mind. What are the different stages of CRPS? Well, stage 1, you find pain is limited to the site of injury. There's increased sensitivity to the skin, localized swelling, not the generalized, but localized, muscle cramps, stiffness, and limited mobility. Initially, the skin, the limb is warm, red, and dry. Please remember, CRPS can be categorized as CRPS warm type and CRPS cold type. It is CRPS warm type, which is very much amenable in the earlier stages to therapeutic. But cold type, you may find it difficult to treat. And there is increased sweating or hyperhidrosis. In stage 2, pain becomes more severe, more diffuse, and swelling tends to spread. And you find more of a, the change is from soft to hard brawny type, hair becomes coarse, nail become more brittle, cracked, and you find there is maybe an evidence of osteoporosis and muscle wasting starts. In stage 3, everything atrophic. And you find for many patients, the pain becomes intractable and may involve the entire limb. So a small percentage of patients have developed generalized reflex sympathetic dystrophy affecting the entire body. I'm sure you easily make out the changes. There has been an evolution of CRPS, subgrouping, that phenotypic grading, subgroup 1, 2, and 3, all subgroups, all groups similar in pain duration and demographic. There are few who suggest, but it is not always mandatory. Please remember. Bone scans can be done. You may find bone, erosions. You may find osteoporotic changes there, but it is actually not always required for making a diagnosis of CRPS. It is mainly a clinical diagnosis, as I said, based on symptom and signs. But there are few physicians who would like to do EMG or who would like to do nerve conduction velocity. But please remember that just by doing EMG and nerve conduction velocity, sometimes the pain can get exaggerated and patient may complain of severe pain following the conduction of nerve conduction velocity and EMG. But for research purposes, yes, EMG and NCV, they only show the integrity of the large diameter fiber. For the small diameter fiber, the best thing which is used as a research tool is QST or quantitative sensory threshold. This is where you find A delta C fiber involved, in almost 80% of patients, and you find that CRPS research, yes, has made huge steps in recent years. You can find association of CRPS with migraine or cluster headache. You may find CRPS happening even in fibromyalgia patient, FMS, and there are luckily now CRPS phenotypes have been classified. You find new pathophysiological changes and concepts have come up. A lot of research has happened, but ultimately you must realize that it is actually, there is an underlying neurogenic inflammation, right? Please remember that. There is also, what we call it as, the peripheral sensitization. There is central sensitization. There may be immunologic underlying changes. And at the same time, there is evidence of autoimmune changes also. Please remember that. In addition to dysregulation of autonomic system, there are neuroplastic changes. There is sympathoefferent coupling. And this particular figure shows that evidence that after tissue inflammation, sensitized primary efferent neuron acquire norepinephrine sensitivity, which is really bad. And once they acquire norepinephrine sensitivity, it will release prostaglandin, so you see the cycle is happening like that. Within the normal DRG, sympathetic axons are only formed accompanying the vessel. That's a normal phenomenon. But after peripheral nerve injury, you find there is extensive sprouting into both dorsal root ganglion and spinal nerves. And there is all as sympathetic baskets wrapped around the median and large dorsal root ganglion neurons. You find this sprouting is there. It is currently unclear that what actually suggests that sympathetic sprouting is associated with an underlying neurogenic inflammatory response, right? So that's very important. If you see, we number only 50 to 60% of CRPS patients actually sympathetically maintain. So where you find always resort to sympathetic. So that's another thing. But on the basis of that, you can always classify it as peripheral inflammatory phenotype and central neuroplasticity phenotype. So we have the neuroinflammatory underlying changes, hypoxic response. There is hypoxia. There is dysregulation of autonomic nervous system. There are changes in somatosensory system. There are evaluation is very important, and psychosocial support is required for CRPS patient. Interaction with this cascade, you'll find there is release of others also, which we'll talk about. Now, over there, in this particular slide, you'll find there is M1 and interleukin 8 are increased. The levels of anti-inflammatory like interleukin 4, interleukin 10, and transforming growth factor, they are lower. So one has to remember that there is effectiveness of bisphosphonate and steroid shown in several studies. And this anti-TNF agents show limited efficacy, but bisphosphonates have a high level of evidence in the management of CRPS. Now, you see, we were talking about hypoxia, we were talking about nociceptor sensitization, and you find there is evidence of increased lactate level, muscle acidosis, decrease in there is a kind of imbalance between there's increase in cytokine inhibit endothelin nitric oxide, levels of nitric oxide is lower in the affected limb. And percentage limb of this. Now, please remember when we talk about CRPS can develop falling fracture of the distal end of the radius, falling fracture of the scaphoid, falling fracture of the fifth metatarsal, and also falling fracture of the ankle joint. So please remember that these are the things which can happen. And recent research, CRPS reveals that promising seems to be the analysis of presented clinical symptom and more promising to draw conclusion based on pathophysiology-based classification. All right. So there is evidence of peripheral sensitization. The motor function is also impaired, and there is evidence of underlying neurogenic inflammation. We said there is also dysregulation of the autonomic nervous system. That's very important. We said warm CRPS, and then in the later stages, cold CRPS. because of increase in alpha-adrenergic response. And so that kind of thing. Systematic catecholamine levels in the chronic CRPS are actually lowered, indicating local absence. There's an important role played by alpha-adrenergic receptors. And this is the evidence where you find, yes, adrenergic agents generate pain and hyperalgesia. Adrenergic antagonists like phentolamine, phenoxybenzamine, they block the noradrenaline or capsaicin on the capsaicin-treated skin. Even there is role of clonidine also. So these are all the evidences in favor of alpha-1 stimulation, alpha-2 stimulation, and topical clonidine or transdermal clonidine alleviated the hyperalgesia in CRPS. So please remember that histopathology shows there's loss of A delta and C fibers. We said their axonal density is reduced almost 29% less, and you'll find there are neurophysiological changes, and accordingly you'll find the symptomatology is there. It is also seen that if you actually corroborate that particular affected limb with the somatosensory cortex higher up, you'll find there is in the somatosensory cortex, which is corroborating to that particular affected limb. So this is also very important. And also remember, as I said, in addition to substance P, glutamate, and bradykinin, there is important role played by NMDA. Why I say that? Because there is an important role played by ketamine infusion. At the same time, when we use intrathecal baclofen autonomia, this reverts back to normal. What is the reason? Because GABA receptors are also involved. There is GABA receptor involvement in the sensitization, gamma aminobutyric acid. Right. There are CNS changes. We said dystonias, myoclonus, paresthesia, tremors can happen in later stages. There is evidence of microgliosis in cadaveric CRPS patient, increased expression of spinal inflammatory mediators, TNF-alpha, interleukin 1 beta, interleukin 6, and so many others. This is the shrinkage or representation, as I said, the weakness, neglect-like syndrome where the somatosensory cortex is contracting, right? This is what I said. There are damage to the small fibers and other extremities involved, and severe dystonia. All right, CNS changes, you find there is cognitive memory aberration in CRPS patient. Please remember social support. Please remember, and it has been seen that as I said, NMDA mediated cortical neuroplasty reversible with ketamine in somatosensory cortex, amygdala, which is involved in emotional functioning. There are changes in the hippocampus, which is involved in memory. So even in the memory also gets affected. That's very unfortunate. Generation of small diameter peripheral axons, small fiber dysfunction. So all these kind of things, in the rat model also they have seen changes. This is where you will see the expression of alpha-1 adrenergic receptors, the reddish one are showing. That is the expression of alpha-1 receptors. Following neurogenic inflammation, you find there is an unmasking of the latent alpha-adrenergic receptors present on the nociceptors, which is very important, right? So what we need to find out, does it happen in humans? Those were actually the sections of the animal models, but does it happen after limb fractures? Yes. Does it spread to the spinal cord? Yes. And what starts the process? That is something still people don't know what exactly is happening. That is, here you can see it is an interaction between different types of nerves. You see the greenish one are pain fiber, the red one are adrenergic fiber. Okay, and this is where you find this on the nociceptors, and there's a kind of sympathoefferent coupling happening over there. Psychological factors are there. We said kinesiophobia, disuse, rigidity, and muscle atrophy. Very important over there. Now, dynamic temperature difference, as I said, 0.8 to 0.1 degrees centigrade between the affected and the unaffected. All right, these are the changes which have been seen following the thermography. All right. So actually speaking today, plain X-rays are insensitive. There are no serum markers, of course. or two I'll talk about. Three evidence of increased bone metabolism happening in patients of CRPS, and that is why they have brought out an increase, this kind of biomarker, an increase in osteoblastic activity marker, which is osteoprotogerin, happening in the serum of CRPS patients. So that's an important biomarker, osteoprotogerin, right? And this can show the response to your bisphosphonate therapy also, all right? And then, so it's a new biomarker, and this is where you see it has good sensitivity and specificity of 0.74 and 0.80, and persistent osteoprotogerin rise in CRPS patient reflects an increase tracer uptake in three-phase. There are pseudomotor, vasomotor changes. There's a neglect-like syndrome. This is post-herpetic neuralgia along with CRPS. There are certain unusual and CRPS and pruritus, CRPS of the mouth, CRPS is seen, CRPS and post-herpetic association has been seen with chocolate intake. So all and CRPS and diabetic. Now, how to prevent it? Well, it has been seen that when you are actually trying to, there is evidence when you are using vitamin C, and it has been seen that up to 1500 milligram for 50 days, it can. So it has been seen that when you use it for 50 days, following the fracture, any kind of fracture or distal fracture in the treatment of CRPS, the first and the fourth, three things. One is physical therapy, second is bisphosphonates, and the third one is spinal cord stimulation or peripheral nerve stimulation. These are three things. So scrubbing and de-scrubbing kind of physical therapy techniques, occupational therapy. This is some of the work which has been done. Intravenous ketamine. Always remember that this particular ketamine, which has been used, as I said, because of an NMDA receptor involved, it reverses the change in the early stage. And here, this microRNA 548D5P has been used as a biomarker for indicating a successful treatment following ketamine infusion, in CRPS. Now, how to give it? This ketamine, we must remember, must be used in a maximum dose of 0.35 milligram per kg per hour for maximum of 4 hours, right? For a good number of days, at least 10 days. So, aapko fail 10 days, which is large, but they have to come. Then only you can you can treat it. Otherwise, any dropout will affect the progress. So, significant reduction in various pain parameters has been seen. In addition to that, we move on to the other one. This is what is the role of sympathetic blockade? Not the gold standard, but please remember that yes, sympathetic blockade does play an important role in the sympathetically maintained pain in 60% of CRPS patients. There are pictures have been taken, functional MRI, increased cingulate activity, decrease in contralateral thalamic activity, as you can see here. And finally, this research is very important. A lot of projects and a lot of collaborations are going on. Can CRPS involve the internal organs? Yes, to a certain extent. Chronic pain as such, whenever you are managing this patient, you have to look after cognitive, sensory, discriminative, and affective component, motivational component for and different type of genes can be involved. And this is where you see impaired insular function has been seen, which is an important finding in CRPS patients. Impaired insular functional connectivity in patients of CRPS. Specially defined motor deficits. Again, as I said, their disruption of motor performance, which is very unfortunate. These patients, they perform worse than the task is performed on the affected side. So you can always have a gene, environment, and genotypic, phenotypic environment interaction, which is others don't. So I think genes, expression, overexpression, there is a manifestation of dystonias, it has been seen. And then impaired empathic ability. So, providing, as I said, the psychosocial support to these patients is very important. Very important, because of the psychological change when we are actually talking about sympathetic blocks are the choice behavior in the management of CRPS. Please remember, but not in 100%. I would still say 60 to 70%. For the pain specialist, when you're taking up stellate ganglion block or your this you call it as lumbar sympathetic block, they are the rise and data. The story begins with sympathetic blocks and ends at sympathetic blocks. But in between, please remember, you can always use bisphosphonates. Bisphosphonate, as I said, along with sympathetic blocks will play an important role. When we talk of bisphosphonate, there is high level of evidence. Please remember, bisphosphonate, were used mainly, I should say, in the management of osteoporosis. So how can we forget that? So that aspect is very important. Wound resorption, right? This is very important. And also they may have complex interaction with the underlying pathophysiologic mechanism. We have the example like alendronate. Oral alendronate you give for almost 40 milligram, right? Alendronate daily for 8 weeks. Oral alendronate. This reduces the severity of CRPS. You can give intravenous alendronate in a different dose. Please remember that. Okay. Similarly, neridronate. Neridronate is another one. Total 400 milligram. 25 milligram once a day for 16 days. That's for intramuscular neridronate. So please remember. If you want to give intravenous alendronate, the dose is almost 7.5 milligram. Right? So the doses can vary. Similarly, but intravenous alendronate will be required for 8 weeks. So these things are very important, okay? And that is where, all right, so bisphonates play an important role. Always remember that. Now, to conclude, I would like to emphasize that, yes, it's a long name. It's a 27 characters, CRP in animals and human beings, but still, we don't know the actual pathophysiology which is underlying. So treatment is chaotic. But, why I'm using the word chaotic? Because you can use, as I said, physical therapy. You can use peripheral nerve stimulation. There has been a recent German study in 2022, published in 2022. And, at the same time, the health regulatory team. Always remember, develop a rapport with the patient, which is where physical therapy, bisphosphonates, to a certain extent, ketamine, followed by your interventions like spinal cord stimulation and peripheral nerve stimulation. So the whole thing is going down system, and neurogenic inflammation is there, and autoimmune phenomena also plays an important role. People have used Pregabalin, and you find there is resolution of the symptom and signs, and the severity goes down. So that means there is an autoimmune phenomena operating. Whatever we say, and I would like to conclude with this last sentence, that high evidence for physical therapy, bisphosphonates, to a certain extent ketamine, then you have the peripheral nerve stimulation and spinal cord stimulation. But all this understanding may, which underlines the cognitive and emotional changes that the CNS is involved. The structural and biochemical changes happening, new therapeutics in the management of CRPS. That's all. I think. Thanks very much for your kind attention. Please, I would like to end up with this particular Deepak Chopra's commentary, that you have to know the reality and the real, nothing shall last but the eternal. Thanks very much indeed for your kind attention, please. Thank you so much.
Thank you so much, Prof. Saxena. Well, that was kind of a masterclass that you had on, complex regional pain syndrome. What a class, and what knowledge that you brought in, quoting the latest studies, 22, 23 even, that you have in your presentation. That's a wonderful thing. It's always a pleasure listening to you, full of logic, full of wisdom, full of, the latest research on that particular subject. I think we'll have, with having listened to your topic, I don't think there will be any doubts in the minds of the people who are there. But yes, as the custom is, as is the normal routine that we have, the question answers will be at the end of the session. So I'll give you a bit of a break now. I'll introduce Dr. Gaurav Sharma, who is the next speaker. Dr. Gaurav Sharma is the Associate Professor, Department of Pain and Palliative Medicine at SMS Medical College, Jaipur. And he's a fellow of Center of Pain Management, Kentucky, USA. And he's also the fellow of Indian Academy of Pain Medicine, fellow of Asclepius Academy of Pain, and is a certified palliative care provider. He's also a certified instructor, essential pain management program developed by Australian and New Zealand College of Anesthesiologists. And he has contributed 2 chapters on how to start and run pain clinic. And he's also the co-author of 4 chapters in consensus statement on role of tricyclic antidepressants chronic neuropathic pain, which was published in 2015. And Dr. Saxena was the chief editor of that book. And he's also the member of the editorial board of Indian Journal of Pain, course director for basic certification program pain management for nurses, faculty in certified course in sports medicine conducted by Government of Rajasthan. And he was the team member of who organized the 32nd National Conference of Pain Society. He actually organized the 32nd National Conference of Pain Society, ISSPCon 2017, Jaipur. And of course, he is treasurer of the Indian Society for Study of Pain, current treasurer and general secretary of ISSP Jaipur City branch. A lot of big achievements for Dr. Gaurav Sharma. And Dr. Gaurav Sharma, you can go ahead with your with the sharing of your screen now. It's over to you. He'll be speaking, friends, he'll be speaking on trigeminal neuralgia, which is one of the very, very commonly seen chronic pain conditions in the pain clinics anywhere in the country. This is very, very disabling for the patient. It's so difficult to, sometimes since the patient suffers so much, there's so much of pain, severe pain, patients can't sleep, can't eat, can't, smile is far away. So patients have a very, very difficult life. So he'll be speaking on trigeminal neuralgia and how to manage that. Dr. Gaurav, it's over to you now. Kindly share your screen. Dr. Gaurav. Dr. Gaurav. Dr. Gaurav, you are muted. Kindly unmute yourself and please start sharing your screen.
Yes, sir. Very good. Your sound. Yes, sir. Am I visible?
Yes, you are visible. Kindly make it full screen. That will look better. Please make it full screen. Yes, that's right. It's excellent. So this is the CV that we have displayed. And Dr. Gaurav, you can please go ahead.
Okay. So the topic is trigeminal neuralgia and the pain management options. What we have, the most common option for the pain management after the pharmacological treatment in form of minimally invasive treatment, we go for radiofrequency ablation. So I will cover this RF ablation for trigeminal neuralgia in my topic. So it's one of the most severe pain what the mankind knows. It is first described by the Aratias in the 1st century AD. So it's a very, very old known pain, and it's a electric shooting like pain. Pain is agonizing, paroxysmal, lancinating, and lasting few seconds in one or more division of the trigeminal nerve. And we all know that it is triggered by the simple activity like chewing, speaking, brushing the teeth, or touching the face. So simple non-noxious stimulus can produce the pain attacks. So ISP gives the definition for the diagnosis that it is sudden, unilateral, severe, brief, stabbing, recurrent pain in one or more branches of 5th cranial nerve. International Headache Society also give the definition. That is very important. We all know. So this is the demographic slide for the trigeminal neuralgia. We know the peak decade of the incidence is 50 to 70 years. And the division is most commonly V2 and V3 simultaneously involved, and in 32% cases. V3 and V2 can be involved 15 and 17% isolated, and there are 70% cases where all the three divisions of trigeminal nerve is involved. So we should know about the dermatomes, where the V1, where the segment is V2, where the V3 segment, and according to that, we have to make our diagnosis. We have to make the clinical, because the clinical history, the trigeminal neuralgia, the clinical history is the most important thing by which we can give the diagnosis. Here, the role of investigation is just to exclude the causes by which it is producing. So the diagnosis is mainly made by the clinical history. So it's very important. So we all know the branches of the V1 and V2 and V3. So what are the treatment? They are the percutaneous techniques which can be used for treating the trigeminal neuralgia. We can target the peripheral nerve, we can target the ganglion, we can go for the neurolysis. So we are focusing on radiofrequency ablation in this lecture. So first, alcohol injection was given for the trigeminal neuralgia in 1902, and the first radiofrequency lesioning is done in 1965 by Sweet and Websick. Glycerol injection is used in 1981, and balloon decompression. That is also a very good minimal invasive technique. It was used in 1978. So Sweet used the radiofrequency thermocoagulation for treating the pain of the trigeminal neuralgia in 1965, where we produce the lesion by the thermal injury and by which we can achieve the pain relief. So procedure, what we achieve, we go through the foramen ovale, target the Gasserian ganglion, and then we go for the stimulation, first sensory and then the motor. After confirmation of the nerve location in the by the trial stimulation as well as the C-arm picture, we go for the lesioning. We can go for the radiofrequency lesioning, we can go for the glycerol injection, or we can go for the balloon compression. In all the three, the target area is the same. We go through the foramen ovale and the target area is Gasserian ganglion. So what is the clinical practice algorithm? When the pharmacological treatment is giving insufficient pain relief or the side effects are occurring. So first, whenever the patient comes into the OPD and is complaining and you make the diagnosis of the trigeminal neuralgia, you have to start the medicine. And the medicine you all know, they are the anticonvulsant. We are giving for the relief, pain relief. It can be Tegretol, it can be Oxetol or carbamazepine. Then we can add other adjuvants also. But when the medication are giving the insufficient relief or the dose are such that now the patient is not getting the relief, then you have to go for the definitive treatment. And what is the guidelines? All across the different pain societies, neuro societies, they are giving them when the patient is coming the young, and if there is a compression by the vascular loop, you can go for the microvascular decompression. It's a surgery. And if there is the role of surgery is less in elderly patient, the patient is elderly, they are the more comorbidity, the patient cannot go for the MVD. There is always the best option is radiofrequency ablation. What are the indications for radiofrequency ablation? Can be used for trigeminal neuralgia, cluster headaches, and secondary neuralgia due to the cancer or multiple sclerosis when all the conservative therapies fails. What are the contraindications? Local infection, sepsis, coagulopathy, ICP raised, and major psychopathology. The psychological status should be normal. This is also very important because whenever you are going to the procedure, this intervention, because you have to give some minimal sedations and you have to ask the patient about the stimulation, sensory as well as motor. So you have to be make a very good communication with the patient while you are doing the procedure. So we come to the preparation part in the OT. the procedure is done under the monitor anesthesia care. We have to use the drugs midazolam, fentanyl, and propofol according to the requirement. We have to plan for sedation with good analgesia. Position is supine with the head extension so that we can make the C-arm tilt, oblique, and submental view. We can see that we have to fix the head with adhesive tape. Sometimes it is required, and IV access has to be secured in all patients. We have to give oxygen with the nasal cannula. All the monitors, routine monitoring has to be attached, and we have to prepare the entry site with all aseptic precautions. So equipments, they are the equipments, the needle for the skin infiltration, then the local anesthetic solution, and the RF cannula. It is a 10 centimeter cannula is being used. So we have to use that RF cannula. So it is a 10 centimeter length, and we can use the 2 mm tip or 5 mm tip according to the patient requirement. Sometimes we have to target only one division, then 2 mm is sufficient. But if there is involvement of more V2 and V3 and V1, there are more involvement of more than one segment, then you have to choose 5 mm tip. And it should be curved. It can be straight curved, but it depends on your feasibility or your expertise that in which type of cannula you are more comfortable. But the curved tip is better to steering inside the foramen and around the ganglion. So first you have to go for the infiltration. You have to give the local, and this is just before going into the procedure. We have to look in the little bit of anatomy. AP view, you can see how it looks. So this is your ganglion position. Here you have to target. Submental view, where you have to target, you can see here the position of this is another view where you have to reach. So this is the foramen ovale, this is foramen lacerum, this is jugular foramen. So these are the different views. So you can have the idea in the AP, oblique, and lateral view. The Gasserian ganglion, this is how the foramen ovale. So foramen ovale, the maxillary mandibular division is coming, and then the maxillary division, and that is the V1. So V1, V2, and V3 maxillary, mandibular, and ophthalmic division are coming, and the Gasserian ganglion is here. Gasserian ganglion is formed. So you are coming from the foramen ovale to this ganglion. So with the mandibular division inside the ganglion, here you stimulate. So V3 is stimulate, and inside all you can stimulate V2 and V1 also. So this is a very important picture. You should make all these film in your mental makeup. Then you have to superimpose it on the CM. Then only you can go for the procedure. So surface landmarking wise, patient is supining. You can entry point is very important. So you have to. This is the position of the cannula or the needle. You can say this is how it should look into the AP and lateral view. So almost 3 centimeter lateral to the angle of the mouth, and you have to, when inserting, you have to put a finger inside the mouth so that the needle cannot go into the oral cavity, and you have to direct it towards the ipsilateral pupil. This is the very important point to make the trajectory right. You have to direct it towards the ipsilateral pupil in AP view, and in lateral view it is towards the midpoint of the zygomatic arch. So this is very important when you are going. This is how it works in the C-arm. So C-arm visualization is very important. You have to make your surface landmark and your anatomy, and you have to make all this mental images superimposed into this, because in C-arm you get the bony images. There is no soft tissue. So you have to superimpose all the way view, and the submental view you have to take the picture in the submental view. It is almost 30-degree caudal and slightly lateral 30 degree, and you have to then make the ipsilateral oblique. This maneuver will give you the localizing the foramen ovale. Here in the lower picture, you can see this C-arm, the foramen ovale is coming up nicely. It is in between the mandible and the maxilla. So you have to, it is just a guideline, rough guideline. It may be some degree more caudal, some degree more lateral, some degree more oblique, but you have to go for the ipsilateral oblique to get the foramen ovale in between the maxilla and the mandible. Once you have identified or visualized the foramen ovale, then half work is done. Then you have to go for the needling or needle maneuver. So you have to mark your point, entry point with the help of C-arm and then go inside. This is how you go inside, the needle directed toward the foramen ovale, and in the lateral position you have to go for the distance or the depth. Depth is always taken care by your lateral position. It is under your target in the lateral position is direct angle which is produced by the clivus and the petrous part of the temporal bone. This is the petrous part of the temporal bone. This is pituitary fossa. This is on the clinoid process. So we have to, this is the position in lateral view, and the below one is submental and ipsilateral oblique. So the direction is given by the below one picture and the depth is given by the above picture. So in this foramen ovale, in the middle it is V2, V1 is situated in the medially part and the V3 is in the lateral part. This is again a pictorial diagram which shows where you have to go. This is the clivus, this is the pituitary fossa as you have seen in the lateral position, and the junction or the angle which is produced by the clivus and the petrous part of the temporal bone. This is the your end point where you are coming inside, and the depth is measured or determined by this picture. This is very important, till how long, till how deep you can go inside. This will be governed by this picture. These are some views. There is some mental views. Here you can see the foramen ovale and the RF cannula in place. This is the RF cannula, and this is the whole wiring system of the RF. This is the lateral view. You can see the depth by which you can achieve the depth. So once you have gone inside, the patient will get the pain when you are touching the mandibular nerve or inside. So you have to confirm the position with the C-arm. Then you have to aspirate whether there is any CSF. If there is a CSF, then you go much inside or the retrogastarian space. So you have to withdraw a little bit. If there is a blood, then you are in wrong place. You can put some dye also if there is some confusion. Or especially when you are going for the balloon, then you have to put a dye. Sensory testing you have to do before for checking the confirmation sign. 50 hertz, 0.3 to 1 volt, you have to increase the voltage according to the patient stimulation. Paresthesia has to be achieved along the desired nerve root. If you are targeting V3, then the paresthesia has to come along the V3. If you are targeting V2, then the paresthesia come to along V2 level, V2 dermatome. And if you are targeting V1, then the paresthesia come along the V1 nerve. This is the very important thing. The patient communication is very important. That's why the patient should be in the sound psychological health. Because he or she and you is a very the communication is very important. You have to describe the whole procedure before going into the operation theater. It's a pre-procedural psychological counseling about the test, how you are going, because it may be sudden pain and sudden electric stimulation give him the pain, and it may be very frightening. So if patient is counseled before going into the procedure, then it will be very helpful during the procedure. Otherwise, it may cause havocs in the operation theater. So sensory stimulation done, paresthesia is positive along the desired nerve root, then you can confirm it with the motor testing. So we all know V1 and V2 are the sensory, and V3 have the motor nerve root, motor fibers also. So V3 is the mix. Mandibular has a motor fiber. So we have to stimulate motor fibers with the 2 hertz, and then you have to increase the voltage from 0.5 to 2 volts. So mandibular nerves give you the contraction of the masseter muscles. The stimulation of the masseter muscle you can appreciate. After stimulation, there is you can go for the lesioning. So you have to make lesion. There may be 3 lesion or more. You can achieve with the 60 degree, 65 and 70 degree. It is the general protocol, but you can go for, if the patient is according to the patient, you can go for the 90 seconds also. So there is a different protocol. Sometimes it may be you can go up to 72 degrees centigrade also. But this is the general protocol, 60 degrees, 65 and 70 for 60 seconds. And if you are targeting V1 especially, you have to check bilateral corneal reflex in between the lesioning. This is very important. So this is how the RF machine shows all the parameters. There is a temperature, there is a time, there is a voltage, there is constant impedance monitoring is there. Earthing has to be properly attached. You have to stimulation and you have to stimulate first, and then you have to go for the lesioning. So this is how the procedure is going on. This is submental and oblique view where you can see, appreciate the foramen oval, and V3 is targeting here. So this is a small video. You can see, I will show you the sensory stimulation. Sorry. Something.
So please click on that black screen. Maybe it will enable the play option.
Okay.
So I believe so the video has not put it correctly. That's why it is not showing.
Oh, sorry. I actually, before starting the presentation, I think I have checked it. Okay. Okay. Let's move ahead, because I have prepared that video, the sensory stimulation, motor stimulation, how you should check the motor stimulation, and how you go for the RF listening. So these are the videos, but somehow I cannot play right now. So, okay, just let's move ahead. For RF, once you are done, all the ablations, all the lesion you have made, you have to constantly monitor all the vitals parameters. You have to communicate with the patient that what you are going. Now I'm going to the sensory stimulation. Now I'm going to check motor stimulation. There will be some contraction coming when you are giving the lesioning. So after lesioning, you can put some local anesthetic along with a non-depot steroid to prevent the future neuritis due to the RF ablation. Then you have to shift the patient in the post-procedural room, where you should observe the patient at least 2 hours after the procedure, or check all the monitors. You have to document the pain relief, and you have to write down all the medication for the post-procedural. So it is a very important, very good minimal invasive method to get the one of the most severe pain, where all the other options are not helpful. Advantages are it is very effective, safe, high immediate pain relief, and you can very well repeat it. And it gives you the relief around 3 to 5 years. Sometimes it's maybe more, but you can repeat the lesion, and you can avoid the surgery. There is no mortality, very cost effective in comparison to the surgical option. Some disadvantages are there, some complications are there. You have to be very sure about the anatomy. You should your placement right. You have to do all the C-arm positioning, localization, then sensory and motor stimulation before going to the lesioning. And there may be, but despite of all that, there may be some paresthesia, diminished corneal reflex, and anesthesia dolorosa, which is a troublesome complications. What are the clinical pearls? It's when the old patients comes and there is no teeth in edentulous patient, the needle point has to be a little bit more posterior or lateral than comparison to the patient who have full teeth. So placement has to be confirmed in the lateral view. This is very important. And before going for the lesioning or before giving the drugs, aspiration is mandatory. Aspiration is very mandatory. So summary is, advantage is high pain relief rate with low relapse and high degree of effectiveness. These are few celebrities who have suffering from the trigeminal neuralgia, and they should get the relief. Thank you. Thank you.
Thank you so much, Dr. Gaurav Sharma, for an excellent talk. And I would now hand over the mic to Professor Saxena for for introducing next speaker, and we'll take on the discussion after that. Dr. Saxena, sir.
Right. Thank you so much. Thanks, Professor Baljit. We now have the privilege of introducing the next speaker. Thanks, Dr. Gaurav, for an excellent lecture. Dr. Azka Zuberi. Dr. Azka Zuberi is actually working as associate professor at Muzaffarnagar Medical College. She passed out from King George Medical College, Lucknow, and she has been working. Before joining this place, 2019, she had worked as assistant professor at Subharti Medical College, Meerut. In between, she has worked at AIIMS Rishikesh also. And right now she is working at Muzaffarnagar Medical College right since December of 2019. She has good number of publications. She has the key skills adopted as a pain physician for intervention spine procedures, sympathetic blocks, radiofrequency ablation, joint injections, regenerative therapy, PRP injections, and of course she has taken efforts of learning for CBT or cognitive behavioral therapy. So without coming, between you and the speaker, now I would like to invite Dr. Azka Zuberi to kindly speak on the topic that she has chosen, and that's mainly on the alpha-2 delta ligands, the Pregabalin, Gabapentin, Lacosamide in the management of neuropathic pain. Dr. Azka, please. Thank you.
Good evening, everybody. Thank you, Ashok sir, for giving me this opportunity. I'll be sharing my screen. Can I start? Everybody
Please
can
do.
hear?
Please do.
Yeah.
So my topic is pharmacotherapy in neuropathic pain. I'll try to limit myself to alpha-2 ligands and the main drugs only. So we all know the medical definition of pain, but we need to know what is the operative definition of pain. And it should be somewhere inside our mind that pain is whatever the experiencing person says it is and existing whenever he or she says it does, right? Then only we can treat this pain. So according to the neurological classification, we have nociceptive pain and we have neuropathic pain. And this neuropathic pain is, as Dr. Baljit has already said, it is very devastating because you cannot see anything. You cannot see a wound, you cannot see an injury, there is no history of trauma, or maybe sometimes there is a history of trauma, but there is something dysfunction between of peripheral nervous system and central nervous system, and that too in absence of any stimuli. So it is a very excruciating type of pain, which patient usually says that they have burning sensation or they have lancinating pain going down to the limb, or they feel some electric shock like currents, that is a tingling sensations or shooting pain. So it is very troublesome thing. Then on the top of that, there can be the history of allodynia or hyperalgesia. We all know that what it is, right? Even innocuous stimulus can be perceived as pain. The pain can be continuous or it can be paroxysmal, and there can be peripheral and central sensitization. Now, for the postgraduates who want to take this, I just started with the very basics. So if anybody is seeing, we all know what peripheral sensitization is, but just to revise it, when a normal person feels pain or normal pain is there, then only the affected neuron, it carries the sensation of pain. But when when there is an ongoing process that pain is continuously perceived, then there can be peripheral sensitization, that the other neurons which would have carried the innocuous stimulus as touch or pressure or something, they also start to carry the sensation as pain. That is what we called it as peripheral sensitization, and it is mainly because of the sensitization by inflammatory mediators, by endogenous agonists, or by changes in membrane excitability and God knows what not. So this peripheral sensitization may or may not, over a period of time, can lead to central sensitization, where there can be decreased threshold to the peripheral stimuli. Pehle कम स्टिमुलाई रिसीव हो रही थी, अभी वही ज्यादा स्टिमुलस रिसीव होगा. There can be increased spontaneous activity in the neurons, and there can be expansion of the receptive field in the brain. पहले थोड़े से एरिया में पेन परसीव किया जा रहा था, पर अभी brain is perceiving pain in a large area, and simultaneously limb is also increasing the spread. There is a spread of pain in the limb also. So there can be spontaneous pain, there can be hyperalgesia, allodynia. So for the like PGs, we can see that a person is carrying a message to the brain with a normal speed, but now when central sensitization is there, the amplified signals are going with a very large speed. So we can understand how serious this is, the hyperalgesia, allodynia, their sensitization. And on the top of that, there is disinhibition of the impulses which are being carried. Brain has the responsibility to inhibit the impulses, but there is also a disinhibition of, so all the more pain is perceived more. So we have this DN4 questionnaire, how we confirm that there is neuropathic pain. We ask the patient about the history, and by examination, we ask some certain points, is there burning pain or you feel electric shocks, and we fill this questionnaire, and if the score is more than 4 out of 10, we confirm it as neuropathic pain. So now we know that neuropathic pain has different neurophysiological process, right? So the treatment should also be different. We cannot treat it with normal NSAIDs or any painkiller. So as we find that there are notable similarities between the pathophysiology and biochemical mechanism in epilepsy and chronic pain. So researchers tried to cure this neuropathic pain with anticonvulsants and antidepressants. And to their good fortune, most of them have been able to. So there are some medications which can treat this pain, which can reduce this pain. So what concepts we carry in the treatment of neuropathic pain is we should dampen down the peripheral sensitization. We should dampen down the central sensitization if it is there. And we should enhance the descending inhibitory pathways. So we have some drugs which work on the peripheral level, some drugs which work on the central level, and some drugs which inhibit this descending modulation. So at the peripheral level, we can use local anesthetics, we can use topical analgesics, we can use some anticonvulsants, antidepressants, opioids, or NSAIDs. When we come on the central level, then anticonvulsants, antidepressants, NMDA antagonists, and opioids are the drugs which decrease this sensitization. And for increasing the inhibitory modulation, we have anticonvulsants, opioids, and tricyclic antidepressants and SNRIs. So, and okay, one more thing is there, the neurochemicals. We should know which neurochemicals we should increase and which neurochemicals we should decrease. So the pain initiators like glutamate as substance P, which work at the central level, we should decrease that. That is why we use NMDA antagonists, right? Then at the peripheral level, we should decrease bradykinin and prostaglandins. And what we should increase serotonins, endorphins, enkephalins, and dynorphins. So we have evidence-based recommendations. So the first line therapies for treating neuropathic pain are alpha-2 delta calcium channel ligands, that is Gabapentin and Pregabalin. Then we have antidepressants, and the two categories like tricyclic antidepressants and duloxetine, SNRIs, have been, they have evidence-based results in treating neuropathic pain. So we other adjuvant drugs are also there which can help with this pain, but they are not the primary treating options, but they may help, they may be analgesic in certain selected circumstances. So coming on to the anticonvulsants, which we most commonly use, gabapentin is the most commonly prescribed drug. And let's see what is the mode of action of gabapentin is. There is a voltage-gated calcium channel, and it has an alpha-2 subunit. So gabapentin binds with this alpha-2 subunit and prevents the entry of calcium ions. So when calcium ion won't enter the channel, the vesicles, they won't burst open, right? They cannot release this glutamate and substance P. And so that cannot bind to the neurotransmitter binding site at the postsynaptic membrane. So there won't be transmission of the signals, the pain signals. So that is the primary mode of action of gabapentin, and for that sake, pregabalin also. It also decreases the release of excitatory neurotransmitters, and it also reduces the communication between the nerves. So gabapentin is also decreasing the peripheral sensitization. Now it also interacts with NMDA receptors, which are present in brain. So it is also trying to decrease the central sensitization. Plus, what good thing is it has excellent tolerability and it has a good safety profile. So we can use gabapentin in majority of the patients. The uses are, obviously it is an anticonvulsant drug, but we use it for neuropathic pain. We use it for diabetic neuropathy, for restless leg syndrome, for post-herpetic neuralgia, and for many other things, right? The dosage with which we start is usually 300 mg OD, and we increase it by 300 mg every 3 to 7 days. We should look at the side effects. We should look at the like drowsiness levels, and then we should increase the dose. We can go up to 600 mg to 1200 mg TDS, and this drug's oral absorption is not dose dependent. It is not, the pharmacokinetics is not very linear as is with pregabalin. I'll come to that. And the side effects, we should remember that it has some degree of somnolence, dizziness, nausea, but these side effects usually subside within 1 to 2 weeks. So we should explain it to the patient that, and we should prescribe this drug, mainly HS, Horasomni, that you should take this before sleeping, after dinner, so that there can be these somnolence, dizziness, which will remain for 1 to 2 weeks, and then it will wean off. Also, this is excreted unchanged in urine. So we need to make adjustments according to the KFT, right? So there is good evidence that early initiation of gabapentin prevents the development of neuropathic pain in lumbosacral radicular syndromes. So statistically significant pain relief has been seen when gabapentin has been started for 2 weeks. So we need to know that at least 15 days will be there, at least 2 weeks. We have to make patient take this before we can expect any effect, right? We have to explain this to the patient. Also, gabapentin reduces the intensity and frequency of neuropathic pain, and it also has significantly better post-discectomy results. So now coming on to pregabalin. Pregabalin is more, there are many similarities between gabapentin and pregabalin, but the good thing is that it takes very less time to take the effect, approximately 1 week. So it is all an epileptic drug, anti-epileptic drug with a half-life of 5 to 7 hours. It is very well absorbed orally and has its renal excretion is also it is excreted without being metabolized. So we need to take care of the dosage according to the kidney profile. So this I have told that pregabalin and gabapentin, they have similar mechanism of action. And we mainly use pregabalin for neuropathic pains, for fibromyalgias, for migraine prophylaxis, etc. So how did we start pregabalin? We started at a dose of 75 to 150 mg per day in 2 or 3 divided doses. We started with a very low dose, basically 75 mg HS, and then we titrated in 1 or 2 weeks up to 300 mg per day. These dosage are for an average adult. And the doses should be titrated according to the effects the pain relief patient is getting and according to the side effects. So as you can see, 50 mg pregabalin is equivalent to 300 mg of gabapentin, and above that this ratio doesn't fit, but the basic dose which we start with is 300 mg of gabapentin and 75 mg usually of pregabalin, unless and until patient is very elderly or a very low weight patient. Then this drug should be, both the drugs actually, they should be discontinued very slowly to avoid any rebound effect. Only we could titrate this drug, ask the patient not to stop it immediately, otherwise they can have a rebound pain like that. The side effects of pregabalin is more as compared to gabapentin because its oral absorption is more, so more effect and more side effects. So it is the side effects, usually they are dose dependent. As we increase the dose, the side effects increase. So basically there's dizziness, drowsiness, dry mouth, constipation. Patient can complain of weight gain, edema, or erectile dysfunction. So when we compare gabapentin versus pregabalin, the absorption of gabapentin is slow, while the pregabalin is absorbed more rapidly. And the maximum plasma concentration is attained in 3 to 4 hours after taking gabapentin, while it is attained only in an hour with pregabalin. Also, the absorption is linear. The pharmacokinetics is linear, first order, with pregabalin, and this is not so in that of gabapentin. The bioavailability of pregabalin is better than that of gabapentin. So it has discrete advantages as compared to gabapentin also, and as compared to benzodiazepines or other antidepressants also. It doesn't have an abuse potential, and it is not likely associated with any withdrawal symptoms. There is no interdose anxiety, and then it doesn't affect the psychomotor performance of the patient, etc. So next we have carbamazepine. I just mentioned this drug because this is a drug of choice for trigeminal neuralgia, as Gaurav sir has already covered. Then coming on to lacosamide. It is a newer anti-epileptic drug which is FDA approved. And this molecule mainly acts on peripheral sodium channels, and it enhances their slow inactivation, like local anesthetic type of effects. And it also interacts with collapse response mediated protein, which is mainly involved in neurotropic pathways. So after seeing its mechanism of action, scientists thought that it may be a good candidate for treatment of neuropathic pain. But it has not yet proved its potential, because research have been done in diabetic neuropathies, in small fiber neuropathies, and the results have been inconclusive. And still now it is not approved as a drug for neuropathic pain. It has its own side effects like dizziness, and at higher doses, it can cause vestibular cerebellar dysfunction. The dosage usually ranges between 200 mg and 600 mg BD, but we have to titrate the dose as we are doing with other agents. Now coming on to antidepressants, I'll just like to mention that antidepressants have multiple mechanisms of action, but mainly they inhibit the reuptake of serotonin and norepinephrine, and so it increases its level, and so that is how it works. So the analgesic effect is independent of the antidepressant effects, and it occurs usually at a very low levels. So basically the proven efficacy is of tricyclic antidepressants, that is amitriptylines, or SNRIs, that is duloxetine. SSRIs, they are not as effective. They had been, we can add it as an adjuvant, but they are not the primary choice of treatment. So SNRI is mainly duloxetine, which we prescribe. We should, before prescribing duloxetine, we should look at the side effects, that it can cause orthostatic hypotension. We should at least mention this to the patient. And we could start it at a dose of 20 mg per day, and we can increase it up to 60 mg. The tricyclic antidepressants, amitriptyline, has been a drug which is very cost effective, but it has its own side effects, like the main side effect, which is apart from anticholinergic side effects and serotonin syndrome, it can cause QTC prolongation. So we should look that if patient is elderly or if patient is a cardiac patient, we should look that we are not prescribing at least amitriptyline. We can go for nortriptyline, but not at least amitriptyline. Then SSRI, as I already mentioned, they have been adjuvant treatment. They are not the primary treatment. So at last, I'd like to finish my presentation with this slide, that how do we write a prescription? Am I audible, right? Hello?
Yes, you are. Please carry on.
Sir, because mostly anesthesiologists don't write a prescription. We are not given a training of writing a prescription. So I thought we should include this slide, that whenever we are writing a prescription, we should be very sure what type of pain we are facing. Is it a nociceptive pain? Is it a neuropathic pain? Or is it a mixed pain, both neuropathic and nociceptive? If it is only a neuropathic pain, we should prescribe like gabapentin or pregabalin or any agent, any primary treatment agent which we want. But if it is a nociceptive and neuropathic pain, we should start with a drug for neuropathic pain and a drug for nociceptive pain. Then if we are prescribing, for example, gabapentin, then we should titrate the dose according to the age of the patient and weight of the patient. Sometimes patient is elderly and we are prescribing a higher dose, like usually we prescribe 300 mg HS, we start with. But if patient is very elderly and very fragile and low weight, then even 300 mg can be more for him. So we should start with 100 mg HS, and then we can titrate it. We can add the dosage according to the side effects and the effects, the pain relief of the patient. So we should take this into account. Now, next comes the time with which we are taking the dose. I have seen many orthopedic surgeons or neurosurgeons, they directly start pregabalin BD or pregabalin TDS or gabapentin TDS, and patient is unable to take the drug, and they will come and say that we cannot take the drug because it is causing so much somnolence and so much dizziness and drowsiness that we cannot take the drug. So we should start the drug HS, and then we can, when the drowsiness and these side effects have been settled down for a week or two, then we can increase the dosage to BD or TDS as we want, as the patient's pain dictates. Now, we have to add adjuvant medications. Yes, if patient is having muscle spasm, we have to add muscle relaxant. If patient is having severe depression, we have done a psychological examination and we think that patient is having a depression, we should add SSRIs or tricyclic antidepressants. If we have started only with one neuropathic agent and patient is not feeling very satisfied after taking that neuropathic agent for pregabalin for 1 week or 2 weeks and gabapentin for a month, then we can add like other tricyclic, we can add tricyclic antidepressant, we can add duloxetine or anything. And the last point is we should explain the side effects to the patient. We should explain it clearly that you will feel drowsy. When in the morning you will wake up, you will feel somnolent, you will feel like you are having dizziness. But these are the side effects, and these will settle down in a week or two. So you should take the medication, and these side effects will be there. You can, and you will have constipation after taking this drug. So if you are already constipated, you can try giving a laxative, or you can try natural methods of relieving the constipation, because after taking this medication, you'll still have these side effects. And if patient is coming with like edema after taking pregabalin, we could tailor it down to gabapentin, because gabapentin has less side effects as compared to pregabalin. So prevent the side effects. If patient is having gastritis after taking nociceptive pain, add an antacid to that and complete your prescription. We could also add like methylcobalamin, vitamin C, vitamin D, that have been known adjuvants to prevent this pain, and they are known for nerve regeneration properties. So we can add these also. These are the combination result is very good. So I think that's all what I have to say for this. And thank you very much. If anybody has anything to ask, that would be welcomed.
Thank you
I
so
think
much.
that was a very basic
Yeah.
presentation, which I made because I thought that the audience mostly will be PG students.
Yeah, that's right. Most of the students are hooked to these webinars because one, they are appearing regularly for the last nearly 2 years, and secondly, the experts that are called by ICA are really top-notch experts in their area. So that's one reason that most of the postgraduate students love to listen to this. Thank you so much for an excellent presentation. I must say that. Prof. Saxena, you there?
Yeah, I'm there. I don't know, my screen is not this thing, but I'm. Thank.
Yeah, carry on from here.
Yeah. Am I audible?
You are certainly.
Yeah. Thanks very much indeed, Dr. Azka, for an excellent lecture. Only thing which I would like to comment is, I know the time constraints are there, is that there are specific clinical phenotypes which have been designed, in the sense that, supposing I say that, as you talked about, neuropathic dimensions like the pressing pain, the pressure pain, and the evoked pain, which we talk about, sometimes maximizing duloxetine to a higher level, 60 milligram per day or 120 milligram per day, which is quite high, can be more beneficial for the presentations of paresthesias or dysesthesias. When the patient says that paresthesias are really troubling, then I think in that extent, you can always take the liberty to increase the dose of duloxetine. The other one is a combo DN study where, your people have taken and, they're applying the combination therapy of pregabalin with duloxetine. You know it very well, right? So it may be say 75 milligram or 150 milligram of pregabalin along with 20 milligram or 30 milligram of duloxetine. That can be done. Unfortunately, what happens is that in India, you always have this pregabalin anti combination in fixed dosage. So you can't, the liberty of titrating the dosage of duloxetine is very difficult. Abroad, they have, the pregabalin and duloxetine separately, but in India, that's the problem. But you very rightly said, but if you go towards the NNT or number needed to treat, you will find for pregabalin, the number is coming as 7.7. The NNT, that's a kind of international currency. For Gabapentin, it is coming as 6.4. So those kind of things are there, but excellent, all said and well done. Well done. I think your presentation was excellent. Definitely. Thank you. Thank you, Dr. Baljit, I think.
Thank you, sir.
There are two questions that I can see in the chat box. One is from Dr. Ashok Jadon. He says during V3 stimulation, this question is for Dr. Gaurav. And he says during V3 stimulation, if pain sensation is felt in the ear, what adjustment should be done? Dr. Gaurav, please.
Yeah. So Dr. Jadon has asked about it. The auriculotemporal nerve is the causative thing. So you are positioning in it's a branch of mandibular nerve. So if you are getting the pain in the ear, then you are getting, that's why that indicates that your positioning is slightly more posterior. If you are seeing like this, V3 division, the terminal branch, one is mental, another this is auriculotemporal. So you have to withdraw a little bit and coming little bit more anterior to get the get rid of this sensation. This is slight manipulation. You have to do it.
I think with experience, experience and slight manipulation, you can kind of get your needle to the right point where exactly it is required, rather than bothering the ear along with that.
It's a very common occurrence, rather.
So that's probably the reason that he has asked, because he might have seen in some patients somewhere. There was another question. I say was because that has already been answered, and this was, what is the difference between pregabalin and gabapentin, and which is best for which type of neuropathic pain? And this was from Dr. Muthukumar Rajagopalan, and he has already thanked Dr. Azka because he got the answer. She had explained it very very well. I can see one more. Gabapentin is the most prescribed and pregabalin is the most studied. Well, this is from okay, Dr. Azka has written that. So these are the kind of questions that we have. Does dexmedetomidine used for CRPS? This is again one question which is coming from.
I have already.
I
have already answered that one. I've already answered that one. So chat box, I was one which has been used. They have seen both in experimentally. When you inject phenylephrine and you get the blush up, and then when you use clonidine, it is all resolving. But dexmedetomidine is not at all, and there's no you can't even have a null hypothesis that why I should be using dexmedetomidine unless until we really want to provide sedation. That's all. So that's the way I think. No point using dexmedetomidine in CRPs, definitely.
So right, that
so
is the kind of question. Yes. Please go ahead. Dr. Saxena, you was
No, I
speaking.
was asking, is there any more question? Any more question?
I
Any
can't see
more
there in the chat box. Probably the presentation was so mesmerizing
because
that it made their concepts very, very clear. And starting with yours, that was a cherry on the cake. Excellent presentation, all three of them. If there is any comment that anyone would like to make it, please go ahead. Otherwise, we call it a day.
Thank you, sir. Thank you for inviting and interacting with you all. Noble.
Thanks, Dr. Gaurav. Thank you.
Dr. Gaurav,
for
I
being there.
ask, right? Hello.
Yes, please.
You are
Please go ahead.
you are using pulse RF or standard RF for this trigeminal neuralgia?
No, it's a conventional. It's a conventional. There is
Because
no
we are
role of pulse.
speed
Yes.
also, and you are using this conventional RF and you are doing motor stimulation also, then that will cause weakness of the masseter, right?
But that is not all fibers, sir. You have to, that muscle fiber is in only mandibular nerve. Okay, it's a partial motor.
What
It's
I
a
am
mixed
saying,
nerve.
if
So you
there
have
is speed neuralgia,
it's for the confirmation of V3. When you are going more inside, when you are going more inside into foramen ovale, then you can go the terminal part of V3 where the conjuncture of the V3 and V2 there. Then you have to cover that part. If you are covering the part where the V3 is starting in the entering into the foramen ovale, then there might be some damage to the motor fiber, but that is not much. But if you are you have to be little bit of careful where the more motor stimulation is there, then you have to go a little bit away from them. And the 60 degree, 65 and 70, they are not getting that much damage to the motor fiber. But the important point, the take home message is you should not go before entering to the foramen ovale, because there it's only V3 is there. So you have to go a little bit inside the foramen ovale, then stimulate and then do the lesioning. Pulse radio frequency, there are a few papers even in from our India itself. One from the Kanpur and one from the Lucknow. They have compared the conventional versus the pulse radio frequency in trigeminal neuralgia, and they found it as all over the world that pulse radio frequency doesn't have a role in.
Also, I just want to ask, somebody asked me in a conference, I was teaching trigeminal, and somebody asked me that heat sink is there. You have CSF, heat sink is there.
Yes, yes.
You have CSF nearby, and many a times your needle, you can aspirate CSF. Then also you are
if there is CSF, then you are in the retroglycerin space. Okay,
yeah, but
you are going more posterior. So you have to little bit withdraw the needle and then you can do the lesion.
Heat sink is nearby. So we are using same temperature like we are using for others. So if there is some aspiration of CSF, or so will we raise the temperature of RF or something like that? So I didn't had answer.
In CSF, when you are in the retroglycerin space, there is no need to go for this. Then there will be no effect. You have to go a little bit, you have to withdraw the cannula a little bit and you get you stimulate and you have to aspirate. That's why aspiration before giving the lesioning is very important, because you cannot predict every time. So if there is no CSF, then you are in the right space. If you are in the CSF, you can do the lesioning, but there will be no effect. So you have to. So there will be no effect. So you have to go a little bit. You have to withdraw a little bit. Just minute changes.
Thank you very much.
These are small tips.
Dr. Gaurav, if I can add,
go ahead.
Sir, please.
Please go ahead.
Gaurav, yeah. You know, when you compare the decompression produced by balloon, right, the Fogarty or whatever you are using, compare it with the the conventional RF, you'll find that, as you said, the duration of relief is 3 to 4 compression. The balloon decompression they've seen, it lasts for almost 8 to 9 or 8 to 10 years. So that long-lasting effect, that's a bit of an advantage with balloon. But everyone won't be comfortable with that, yeah.
Plus, other thing which I can think of with the balloon is that the incidence of bradycardia is very, very high, and that remains a bit of a risk. And in case you're going ahead with balloon, then I think there should be a separate team who would look after the patient while you are doing your procedure, because you can't have one eye on the patient and on the monitor and one eye on the patient. So this is going to be difficult. So you must have a full ready team just in case bradycardia becomes too severe to affect the hemodynamics. Yes, Dr.
Balloon
Gaurav,
is best. Balloon is best when all the three divisions are there: V1, V2, V3. Because when we are covering the V1 with the radio frequency, then the chances of ophthalmitis or keratitis is there. So that's where the balloon should be used, because the entry or the cannula balloon, the size is 14 gauge. So that is also very, very pain. It's a painful thing. Despite of all local anesthetic you have inserted, it's a little bit wider gauge. So you have to choose when V1, V2, V3 is there, then you should you can choose the balloon with all the precautions like bradycardia and all. Anesthesia team should be there. One anesthesia person has to be there. Even I should say that for the RF also there is a separate person. Anesthesiologist has to be there. Because you need to put propofol, fentanyl, analgesia, and simultaneously, so you become free from all that part and concentrate on the on the procedures. So it should be always there. One standby anesthesiologist has to be there in all procedures.
Always. Has to be.
Very true. Very true. So, any more comments? Ms. Devlin has already said that there are no more questions in the chat box. And if that is the case, I think we can call it a day. And before we call it a day, I have a very, very, very very pleasant duty to, thank you all on behalf of the President, Dr. Radhakrishnan, on behalf of my colleague, CEO, Dr. Jayashree Sood, and of course, my personal behalf and the whole team from ICA. Thank you so much. All the three talks were excellent, full of knowledge, recent knowledge, and not only just knowledge, it was full of, experience, your wisdom. The small tricks of trade which you all have given, I think that would go a long way in helping the youngsters to make their procedures more painful, more pain-free, as well as not only pain-free at the time of doing, they would give more relief to the patients. That's what your target is. And apart from that, it will give you tremendous feeling of satisfaction that you've done a good job at the end of the day. Thank you so much, friends, and all the very best, for your future, and look forward to having you again on this program sometime later. Thank you so much, and good night.
Good night.
Thank you.
Good night, everybody.
Good night.
Good night.
Thank you.
Lovely. Thank you very much.
Thank you. Thank you. Thank you.
Pranam, ma'am.
Thank you.
Thank you, Gaurav.
How are you?
Thank you. And thank
you.
you, Azka. Thank you so much.
Thank you, ma'am. Thank you.
Bye-bye.
All good night.
Thank